Addressing mental illness in the United States is an urgent problem. Each year, 50 million Americans will struggle with mental illness, but only half of them will receive treatment, often because they can't afford ongoing care or the treatments they've tried simply haven't worked. But what if I told you about a new class of medications that, when combined with therapy, could help solve this problem? Medications that, after one dose, could effectively cure depression, even in people who had failed other treatments. Or medications that could finally provide relief for folks with treatment-resistant PTSD who had struggled for over a decade. Not only are these treatments effective, but participants say that experiencing therapy with these medications was one of the most meaningful experiences of their lives. These are just a few of the outcomes that we're seeing with psychedelic-assisted therapy. Treatments that combine a few doses of psychedelic medicines with supportive therapy to enhance and accelerate healing. And these results are not anomalies. Over the last 2 decades, hundreds of studies have come out validating the potential of psychedelic medicine. And while this is a paradigm shift for Western medicine and how we think about treating mental illness, this knowledge is not new. For centuries, indigenous communities have been using psychedelic plants to facilitate individual and community healing and spiritual practice. It is only because these communities have shared this knowledge with the West that we even have a psychedelic revolution today in medicine. And it's important to note that psychedelic medicines are not magic pills that work for everyone or a silver bullet. When they work because they combine the psychedelic experience as a catalyst with what we already know works: safe therapeutic containers held by skilled providers. And while the research is exploding right now, it's still in its infancy. We need more and better studies, especially those that compare psychedelic medicine to gold standard treatments and those that study marginalized communities. But what we are seeing with the evidence we have is astounding. Under the influence of a psychedelic, patients report that they can access difficult content, traumatic memories, without becoming dysregulated. They report greater insight and dramatically improved self-compassion. Neuroscience research is showing us that psychedelics can temporarily make our brains more flexible, allowing us to forge new neural connections and reinforce new ways of thinking and feeling. In one participant's report, I had never had that experience before, where I could just sustain, trust, and listen, tell the whole emotional truth, and say exactly how I was feeling. That was the MDMA for sure. I would never have been able to do that. Another participant noted, the psilocybin just opens you up and it connects you. It's the first time I've ever really felt like I was part of the world instead of separate from it, and I have kept that feeling ever since. These are quotes from studies with MDMA and psilocybin, the active ingredient in psychedelic mushrooms, but I could have given other examples with LSD, ketamine, 5-MeO-DMT, and ibogaine. Collectively, these psychedelic medicines, when combined with therapy, are being shown to treat PTSD, anxiety, depression, substance abuse, suicidality, and end-of-life distress. That is why hundreds of clinics across the country are starting to provide ketamine, which is already legal to prescribe off-label in all 50 states. That is why Oregon, Colorado, and New Mexico have legalized therapeutic use of psilocybin and are developing state-level programs to license providers to deliver it. That's why the FDA has fast-tracked several psychedelic medicines, and a host of pharmaceutical companies are racing to bring them to market. For better and most definitely for worse, psychedelic medicine has become a big industry, worth an estimated $2.5 billion. And even though psychedelic medicines help us treat things that we as social workers see every day, the field of social work has barely dipped a toe. In a scoping review of research on psychedelic medicine and equitable access, something that should be our wheelhouse, only 6 out of 164 authors were social workers. At this conference, out of over 300 different presentations, only 4, including this one, talk about psychedelic therapy. And while our voices are seldom heard, we have so much to say and so much to contribute to this movement. Psychedelic medicine needs our focus on equity and access. Psychedelic science has been widely criticized for its lack of equity, inclusion, and diversity. Until recently, most of the research was done by white, cis, straight people on white, cis, straight people. And the therapeutic modalities with psychedelic medicine that are currently available, such as with ketamine and sometimes with psilocybin, are generally not covered by insurance and incredibly expensive, making them only available to the wealthy. Psychedelic medicine also needs social work clinicians. We are by far the most prevalent mental health providers, and as a field, we're much more racially and ethnically diverse compared to psychiatrists and psychologists. There can be no equitable, inclusive psychedelic therapy movement without training social workers to do this work. Psychedelic medicine also needs our focus on decoloniality. The psychedelic medicine movement stands on the shoulders of Indigenous communities, yet they've done a horrible job of acknowledging these contributions, building real relationship with Indigenous healers, or giving back to Indigenous communities. And while social work is still in a process of its own decolonizing, we have a rich history of critical social work theories that engage with challenging the legacy of colonialism. And our focus on social justice could help steer the field of psychedelic medicine towards right relationship and reciprocity. Psychedelic medicine also needs our focus on safety and ethics. Sadly, over the past few years, several cases of sexual boundary violations committed by therapists against their patients in clinical trials on psychedelic medicine have been reported. Social workers understand that boundary violations and dual relationships are incredibly dangerous. That's why we have the most stringent code of ethics on them. We understand that healing can only happen with relational safety. And that is why we can help move the field of psychedelic medicine towards more rigorous guidelines and greater clinician accountability. And lastly, psychedelic medicine needs our help to push back against medicalizing psychedelics. Right now, big pharma and venture capitalists are becoming increasingly interested in psychedelic medicine, and it's becoming medicalized, treating individuals like clusters of symptoms in need of correction. This fails to honor that psychedelic medicine has long been used in community settings, not only in Indigenous communities, but in underground queer, dance, and psychonaut communities over the past 50 years. We as social workers often have to work in a medical model, but we've always pushed back against the individualistic, pathologizing lens of medicine. We know that healing happens in relationship, in community, when people feel part of something larger than themselves. Thankfully, there's some exciting new developments that are bringing more social workers into psychedelic medicine. Where I teach at Columbia University School of Social Work, our psychedelic therapy training program is the first of its kind to embed psychedelic therapy training and internship opportunities within an MSW program. And through the University Psychedelic Education Program, UPEP, nurses and social workers from over 30 institutions across the United States have received training in psychedelic therapy, as well as access to free course curriculum and syllabi, so that they can start teaching courses in their own institutions. My own small contribution to this is to try to develop better resources to train the next generation of social workers. That's why I've partnered with NASW Press to write the first psychedelic therapy textbook specifically for social workers. But these are just the beginning stages. Psychedelic medicine is rapidly becoming one of the most evidence-based, innovative treatments available to us, and social workers cannot afford to stand on the sidelines. We must educate ourselves, not only about the potential of these treatments, but about their risks. We need more social workers leading research, evaluating programs, developing trainings, advocating for better policy. We need to stand up for the marginalized communities and low-income communities that are being left behind as these treatments roll out. We need to advocate for care that centers safety and cultural humility. Together, we can build a brighter future not only for psychedelic medicine, but for our communities, our organizations, our clients, and our field. Thank you.